And thanks to all of you for joining us today. I'm Beth Stroll with the TA Network for Children's Behavioral Health, and I'd like to welcome you to this month's System of Care Leadership Learning Community Meeting. This session is part of our System of Care Leadership Learning Community. Denise Silsback and I co-facilitate this learning community for the TA Network. We hold it monthly, and it's designed to support system of care leaders and systems of care. That could be in states, communities, tribes, territories, and it includes both communities with and without federal grants. We do try to address topics that are important and helpful to you in your work, and we're always open to your suggestions for future topics, so please feel free to email either one of us with your ideas. And today's session will be focusing on approaches to evaluating systems of care. We'd like to make these sessions as interactive as possible, so we encourage you to put your questions, your comments, your insights in the chat box that you see to the right of the PowerPoint throughout the session. And we've also incorporated time for question and answer, and Denise and I will make sure that any questions you enter into the chat box are addressed at the end of the presentation. Just below the chat box, you'll see a box that will allow you to download today's PowerPoint and other resources. And as a follow-up, you'll receive a link to the recording of this webinar as well. I wanted to point out that at the end of the session, a link will pop up for a very brief evaluation survey, and we'd really appreciate you taking just a few moments before logging out to complete the survey and provide us with your feedback. We really do take it seriously and use it to improve our future learning community sessions, so we'd be grateful if you would do that. I also wanted to take a quick moment to mention our new learning management system that we're calling Ideas at the Institute. This is a platform that allows our learning communities to be more user-friendly and more interactive. And it's a digital hub where you can go on and join various learning communities that we offer. You can register for webinars there. You'll find recordings of all of our previous webinars and the related resources from those. And you also will be able to interact with experts and peers, among other features. So the link to sign up is on this slide. You use your email as your username, and you click on temporary password change me. You won't be able to use the system until you change the password, and we really encourage you and your staff and your partners to sign up and take advantage of the IDEA system. We're really very excited about everything that it has to offer. And before we get started, I'd also like to mention that our next learning community meeting is June 19th. Also at 2:30 Eastern Time. And the focus of that one will be on strategies for preventing custody relinquishment only for the purpose of obtaining mental health services. You might recall reports by the Bazelon Center for Mental Health Law and the GAO on this about 15 years ago or more. And the TA Network recently completed a project to revisit this practice nationwide and look at whether it's still occurring and why, and what strategies can be used to prevent it. There have also been quite a few news stories about this in the last few months, so we hope you'll join us. Put this on your calendar for next month. Our wonderful tech expert, Tiara, is going to put a link to register for that in the chat box. I see she's already done that. And you'll also get that in the follow-up email that you'll receive from this webinar. And as always, you can find this information and information about all of the technical assistance opportunities that we offer in the weekly TA telegram. So again, today's session will be on evaluation approaches for systems of care, and we're very fortunate to have 4 outstanding presenters with us today. Abram Rosenblatt is Vice President at WESTAT, and he's the Principal Investigator for the National Evaluation of SAMHSA's System of Care initiative. He's going to focus on evaluation methods, instruments, tools that you can use in your own states and communities to do your own site-specific evaluations. And Abram will be followed by presentations from 2 states that will highlight the methods they've used and how you can adapt these in your own environments. First, Geneva Stretch will talk about Oklahoma's work. She's the Associate Director of the E-Team at the University of Oklahoma, and the E-Team has been the evaluator for Oklahoma's statewide system of care work. And then we'll hear from Connecticut. Tim Marshall is the Director of Community Mental Health at Connecticut's Department of Children and Families. And then Joy Kaufman, who's an Associate Professor of Psychiatry at Yale and leads the evaluation for the state system of care efforts, will tell us a little bit about their work. I'd like to thank all of them in advance for their great work in pulling this together. The objectives for today's session will be to describe approaches that have been used in jurisdictions to evaluate the systems of care that they've implemented, to provide an overview of the strategies, instruments, and tools that you might be able to use for this purpose, and then again, to highlight the approaches that have been used in 2 states. And they'll be addressing their measures, their instrumentations, their reporting strategies, and also how their evaluation results are used for quality improvement. So I'm now going to turn this over to Abram, who will get us started. So Abram?
Well, hello everyone, and thank you very much, Beth. It's terrific to be able to talk with all of you today, and I'll be taking you through some looks at state and local looks at evaluation of systems of care, because we are involved in the national evaluation of SAMHSA's Child Mental Health Initiative. There'll be some overlap there, and we'll hopefully find something of use to all of you, and it's really terrific to be able to do this with all of you today. So here's what we're going to do. We're going to look at the Child Mental Health Initiative data collection, largely from the perspective, for those of you who are participating in that, about local use, and also for those of you who are not, to get a sense about how that's going. We'll have some examples of the national evaluation, and also of NOMS data, which is the National Outcome Measurement System that SAMHSA uses with all their grantees. And so we'll be giving you some sense about ways of looking at those data. We'll look at some additional data collection tools. There are many out there. We'll feature a few. There's a lot of interest these days in clinical high-risk and first episode psychosis. We all happen to be conducting for SAMHSA also the evaluation of the mental health block grant 10% early psychosis sites, and so we'll give you a taste of that, which you'll hopefully find of use, and then some comments and conclusions. So that's our overview of the presentation. So here's the framework for the Child Mental Health Initiative National Evaluation. Some of you have worked with us and have seen this, but for those of you who haven't, you may find it useful, and for those of you who have, hopefully it'll be a little refresher. We really turn this into a focus on expansion, because that's the emphasis of the national evaluation, and how systems of care for children, adolescents, young adults can expand. And so we have different kinds of supports that occur. You see over on the left side of your screen. At different levels. We know these are multi-level interventions. They include the service at delivery practice level, the local system level, and the state system level. Those are all places where you may have supports or activities going on. We have a strategic framework based actually on work many people have done, including Beth, on the kinds of things that tend to relate to successful expansion. They include creating effective policy and partnerships to affect policy, the provision and expansion of effective services and supports, financing strategies. It's hard to do things if you can't pay for it, training and workforce issues, and also the way you communicate about your successes in your system of care, and other aspects of service delivery. And we design measures to measure all of these particular items for the national evaluation. And then we have a set of outcomes which include whether the systems actually expand, whether there were improvements in the types of services provided, and an increase in the services and supports. So for example, we may see increases in successful evidence-based practice implementation. And then of course, importantly, improved child and family outcomes. And for us and all of us, the system of care principles undergird everything that we do. So that's our overall conceptual look at how we built our evaluation tools, and they're all structured around this particular model. So we've got instrumentation and measures that, not surprisingly, match the dimensions I was just talking about. For those who participated in this, we thank you. And for those of you who didn't, you might find this of interest. We do an introductory document review. We at WestStat conduct key partner interviews with people who are involved in your systems, including youth and family members, program people, policy people. That encompasses pretty much all of our analytic dimensions. Do them both state and local levels. We do them at 2 points in time to see how these things have changed. We do financial mapping, which looks at financing. We look at how you're paying for services, how systems are paying for services, and benchmarking, which compares how some services are funded with broader potential benchmarks for what funding might look like. Then we have a couple of tools. We have the System of Care Expansion and Sustainability Survey, or the SOCES, or kind of the success, which is clever, I think. We like our acronym for that one. And it taps all analytic dimensions. It occurs at both the state and local levels, and we do that at the second year, and then additionally in other years to see if things have changed. That's a quantitative measure of the System of Care Expansion and Sustainability. We have, which is something probably many of you are interested in, the Child and Family Outcome Study. That, of course, looks at the outcomes of services and supports. We've been collecting that data consistently, and we do it for when youth come into the services and then at 6-month intervals. And by we, I mean actually the local grantees collect this information and report it into our data collection system. There's a network analysis that also goes on. That's very interesting. It looks at policy and partnerships and the different kinds of relationships that you have in your system of care between your local system, potentially state systems, partners, and the various folks you work with in implementing your systems. We do that at both the state and local level, and we've done it twice to see how it changes. So that's a very interesting model that we're looking at. And finally, we do a geographic information survey to see where systems are being provided, where services are being provided. So here are the outcome measures to get to the point. We do the pediatric symptom checklist and the Columbia Impairment Scale. The pediatric symptom checklist is, most of you are probably familiar with it, but it's a short, relatively brief measure that's been used a lot for screening. It looks at symptoms, mental health related symptoms. It has been historically conducted as a screening tool. We adopted it early on as a potential outcome tool, as did some other places, and we found that it's actually been extremely useful for outcome measurement. It's quick, it's brief, you can screen with it, you can do pre and post with it, you can look at whether someone meets clinical criteria. So it's sort of a Swiss Army knife of tools for us, so we found it very useful. We also implement the Columbia Impairment Scale, which looks more at functioning. Together, the Pediatric Symptom Checklist and the Columbia Impairment Scale take very little time to do. They can be done with youth and with caregivers, and they complement each other. The Columbia Impairment Scale looks at functioning, with how people are doing in home and in their school and other settings, and the Pediatric Symptom Checklist looks at mental health symptoms. Because we all care very much about caregivers and families, we utilize the Caregiver Strain Questionnaire to see how caregivers are doing. And then we also look at demographic characteristics. One thing that's really different about our national evaluation compared to prior ones is we also use the National Outcome Measure System-based measures, and we integrate that with the measures that are Child Mental Health Initiative National Evaluation specific. We do that because it's hopefully efficient, since grantees who are getting SAMHSA funds are required to complete NOMS measures. We thought, why duplicate that if we didn't have to? And so we get NOMS data from SAMHSA through a data use agreement, and we then merge that with the data that we collect directly through grantees to collect an overall outcome picture. Some of you will see that, probably have not seen NOMS-based measures and how they look on the outcome side, so hopefully you'll find that interesting. We'll give you some examples of each of these so you can get a sense about what they look like. Here's what we have from the NOMS outcome measures, and here's what we use. We use health status, everyday life functioning, psychological distress. You can see the list here: legal substances, living environment, school attendance and employment, criminal justice involvement, perception of care, and social connections. So these are all areas of measurement that I'm sure we are all interested in monitoring and looking at with the children, youth, young adults who we provide services to and their families. So the NOMS measures are actually relevant, highly relevant to the services that are provided in children and adolescent systems of care. Here's where we get to more interesting parts where we're looking at actual data. We have presented these, so they're public data at this point. And what we're seeing generally is positive data, and this gives you a sense about what the data look like from these outcome measures. So if you're using them, you might be interested in seeing that. If you are interested in potentially using these measures, you might get a sense about what happens after you implement them. So you see here we have a mean at intake and a mean at follow-up. So we have averages, essentially, from time 1 to time 2. And what we see across the board is reductions in symptoms, which is what you want. So positive change. The symptoms are going down. And you have a total symptom scale, which is overall. The externalizing scale goes down to externalizing symptoms are things like acting out and how they're behaving in the external environment, how young people are behaving. The internalizing symptoms, which have things to do with like depression and anxiety, and then attentional issues. And in all cases, we see improvement in these indicators, which is good. It's what we want to see. We also think individual stories are important, and we just wanted to share this story. It gives you a sense of the complexity that we have. And so you can get a look at this quote, and it has you can just go ahead and read it, and you can see how important these services can be and how systems can make a big difference in the lives of young people and families. We actually have a question I see from my good friend Beth about how would jurisdictions that aren't grantees be able to get those to apply to their own sites, the NOMS measures. And the NOMS measures are public. You can see what they are. You wouldn't be able, as a non-grantee, I don't think, to participate in the NOMS data collection that's sponsored by SAMHSA, where you enter things into the NOMS data collection system. But you certainly could implement it and code it yourself, and so those are publicly available, and we can probably give you a link or send you to the right place to ask for the actual tools that they use to collect it. So hopefully that helps answer that question. Here's what functioning looks like from the Columbia Impairment Scale, which is, by the way, a free scale, which is always good. And you can see that there's been a mean improvement in functioning, functional impairment among children, youth, and young adults over time from intake to follow-up. The Columbia Impairment Scale gives you a single overall score, and so we see overall improvement in functional status. So we have improvements in symptoms, as evidenced by reductions in symptoms, and improvement in functioning. Caregivers also show less strain. And we have different types of strain measured by the caregiver strain questionnaire. There's total overall strain. There's the objective strain, which sort of has to do with aspects in which the strain may impact people's lives directly, things like being able to hold a job or get around and do things like that, go to school. Subjective externalized strain, which is how people feel strained, and then internalized strain, which is how they sort of feel psychologically. So across the board, caregivers report significantly less strain after receiving system of care services. So those are all good positive outcomes. And so this is the NOMS data set. And this is a way we look at national NOMS data for CMHI. Should any of you decide to use NOMS, and we don't, at the national evaluation for CMHI, we don't administer NOMS or deal with NOMS except as a data analytic tool the sites we work with, but it's probably useful for all of you to see that it can be valuable. You can see that we have changes really expressed as positive changes in percent positive to percent positive at discharge for each of the indicators. And you have percent changes ranging from 7% or around 2% for involvement with the criminal justice system to 62% change functioning in everyday life. All the change here is it's statistically significant. And you can see that across the board, there are significant improvements in these categories, really mostly of functional status, including perception of care, which there isn't actually a second data point on because you don't generally ask how that changes from time one to time two, but at discharge, 94% of the people served were positive about the services they received. So overall good, great, positive indicators from our system of care evaluation of how systems of care are doing across symptoms, functioning, caregiver strain, and specific types of areas in health, functioning, and overall well-being as measured by the NOMS. And so this is a merged data set for us. There's a lot of additional popular outcome measures, and I sort of was a little worried about making this list for all of you because anytime you make a list like this, there's probably about 20 more that other folks prefer or like to use. These are ones that have historically been widely used and happen to be ones I've worked with. Many of you have probably used or know about CANS, the Child Adolescent Needs and Strengths, which is both can be used both as an outcome measure and also as a way of working toward outcome-based care and service delivery as a feedback mechanism. CANS is very popular. There are numerous states that have implemented it, and there are also child welfare systems and justice systems that have used the CANS. It's definitely worth looking at if you have not familiar with it. The Child Behavior Checklist, which is the grandfather or grandmother of all of these kinds of standardized scales in the child area. You have a parent version, a youth version, a teacher version. There are several versions of it. It's got national norms, national standards. It's the kind of scale you will often propose in a research trial of various types. It covers a wide range of symptoms and functional areas. And again, you can get scores that relate to national norms and standards. Very useful scale, a little bit complicated to implement, which is why it's not always used statewide, but sometimes has been. The Ohio scales were developed, I'm waiting for you all to yell, in Ohio, and it was developed quite a while ago. And some states still use it. It's very practical, sort of a shorter CBCL in some ways, which is a gross oversimplification, but it's a very useful scale. We've used it historically in the past and found it valuable. There's not a lot of additional development going on with it for various reasons, but some states still use it and are still working with and developing it. And the CAFAS, the Child Adolescent Functional Assessment Scale, which was part of the prior national evaluation, so it's actually still in place in numerous places, both because it was used in a national evaluation and some state systems had put it in place. And that's one way you train folks to administer, never really had to administer it. There's a reliability function on it, and it really looks at functional assessment, at functioning, and across a range of domains. So that's the CAFAS. And there are many others as well, but I wanted to give you a sense. I'm going to sort of change areas slightly, and then we'll circle back around and go to clinical high-risk and first episode psychosis measures. Some of you may be providing coordinated specialty care first episode psychosis services. SAMHSA is funding some of those services, as many of you know. And so you'll see that there are a number of measures that we've adopted for our mental health block grant use. And so I want to just kind of take you through those, and then we'll kind of circle back around. We have some fidelity measures we use. Coordinated specialty care is, for those of you who don't know, it's kind of like wraparound in a way, or sort of community treatment. It's one of these multi-area interventions where you have a team approach and you have different components of the team approach, and there are ways of measuring fidelity. So we're measuring fidelity in our national evaluation. We're looking at outcomes, And then there's also underway, stay tuned, a National Institute of Mental Health, very exciting set of grants and funding that they're doing that has to do with, it's called EpiNet, it's the Early Psychosis Intervention Network, and also some tools in this toolbox called FENEX that is online where you can go and look up a whole host of psychosis tools. Around first episode psychosis, I'll just touch on the Fidelity Scale fairly quickly. There are a number of Fidelity first episode programs around the world. There are several countries worth of Fidelity Scales. They can be developed based in a number of ways. Knowledge synthesis, some program may be effective and they measure fidelity, that becomes a standard. There may be some expert consensus. So there's different ways of developing scales. There are some that use research evidence. There are some deriving from program models, and there's some deriving from expert consensus. I won't dig into each of these individually at this point. It might just be useful for you to have. You can search them, or I can, of course, give you some more information on a later point. But just think about, if you're using a first episode psychosis program, that there are first episode psychosis fidelity scales, some of which may match your program better than others. The one that we are using is the FEP-FS. And this is a nice fuzzy, even with my bad eyesight, a look at the 31 items of it. Hopefully you can see it better on your screen, or if you download it, you'll be able to take a look. And these are the items that we're looking at, and there are a range of different kinds of things like referral, crisis intervention services, team leaders, intervention programs for weight gain, community group outgroup, really the components of first episode psychosis services. And this is the scale we're using. It's relatively short. It doesn't take that long, which is one of the reasons we're using it. In the Mental Health Block Grant, we have a set of core descriptors, which we also actually have something like that on the CMHI. They're the ones you would normally see. And you can see that there's age, race, ethnicity, marital status, homeless status, school, employment, mental health diagnosis, legal issues, suicide attempts. It's a good list of core descriptive outcome measures that we found the programs we worked with all were able to implement jointly. These are our core outcome measures. If you're looking for outcome measures for early psychosis, these are the ones we selected with the sites that we work with. They are all implementing these. There's a modified Colorado Symptom Index, which is the core measure we use. It's relatively brief and it's a set of symptoms related to mental health and psychosis. If folks are available, there's the brief psychiatric rating scale, which is also very short, and the Myrick GAP, which is actually a single item symptom scale. We also use the Global Functioning Social and Role Scales. There's 2 items. The Layman Quality of Life Global Scale, which is one of my favorite scales. You go delighted to terrible, and you rate where you are on that on a set of scales. It's useful in almost every aspect of life. And then we have, you can rate the presentation today on it. And then we also recommend the Myrick GAF Social Functioning, which is also a global assessment of functioning kind of rating scale that's very, very brief. Finally, in the FENEX toolkit for early psychosis, there's a whole bunch of domains, and there are tools within each of these. This is available on the website. You can search and go ahead and look. It's public. And you can find tools. So this is a really great resource in each of these areas. Of course, I'm not going to go through them one by one or tell you what all the tools are. That would take the rest of everybody's time. We don't want to do that. And so you'll see that, however, you can get tools applicable to young people who have early psychosis on here in each of these areas. And there's more. So most all the areas you could think of are in this toolkit. In some cases, there are multiple measures. In some cases, there's just one. So here are some broader measurement challenges we faced in early psychosis, and that those of you who are working in the transition age youth area are very familiar with. You know, outcome domains vary from late adolescence to early adulthood. The most simple one is you tend to be focused in late adolescence on something like education. In early adulthood, the focus tends to be more on employment. And there are many, many of these kinds of areas where the big difference between an adolescence and early adulthood, and so the domains vary. The measurement perspectives also vary. So in the adult area, we tend to measure things based on report from the person who's receiving services. In the adolescent area, we often, almost always, will want to report from a caregiver who can report on the young person and from the young person themselves. So you have different perspectives because of the way people report. And then the last one, which I think is worth really thinking about, the child, adolescent, young adult measures were historically developed separately. Until fairly recently, the adult and child mental health research worlds and communities were, to some degree, like the service systems, running on parallel tracks. And so these measures were developed separately. When you get into the transition age range, you often have this kind of problem where measures weren't developed specifically for that group, and you're kind of borrowing from the young or borrowing from the old and extending low or extending high, making them work for older or younger. So there's a lot of work to be done in this area of developing measures for transition stage use broadly, and that, of course, affects first episode psychosis, which tends to occur in the transition age youth population. So finally, that was quick. National measures can be used at state and local levels, which is what I wanted to sort of emphasize in taking you through that. I showed you national data. You can do the exact same analyses at state and local levels. First episode in clinical high-risk sites, those of you who are those, it's a different kind of instrumentation set. The continuity of measurement from child, adolescent, and young adults pose specific sets of challenges for which there are not straightforward answers. If there were, I would have tried to provide them for you, but it's definitely worth attending to. And finally, something we always talk about, and I shared the initial model for this reason, you really want to match measures, and we all kind of know this, but it's easy to forget, to programmatic needs. We changed the national evaluation of CMHI to fit changes in the implementation of the CMHI program at SAMHSA to move really toward expansion and sustainability, because that's what happened with the program, and that altered how we measured things. And at your local level, you'll have many, many, many examples of that. So according to the feedback I'm getting, I have just hit my exact time, and that is my presentation for now. I'll be able to stay on the line for if we get to points where I can answer some questions.
And thank you so much, Abram. Much appreciated. We do have some questions for you, which we will field with you at the end. And now, Geneva, we'll turn it over to you to talk about Oklahoma System of Care Evaluation.
Hello, everyone. Thank you for having me today. I am at the University of Oklahoma. We have the evaluation for Oklahoma Systems of Care. It's actually funded through the Oklahoma Department of Mental Health and Substance Abuse Services. It started in Oklahoma in 1999 in 2 counties, and I think that Oklahoma has been, or DMH actually, has been really strategic in how they expanded. They've applied for federal grants and used those grants to move into new counties, and at the end of those grants, the state picked up the funding for the counties that had just had their federal funding ended, and they applied for new grants. And so I started with Systems of Care in 2005. I always like to say I started right out of kindergarten. But in that time, I've seen Oklahoma expand from 14 counties all the way to all 77 counties through the implementation of health homes. So we have had a statewide focus from the very beginning, constantly looking for how we were going to grow and expand across the state. And because of that, we've had an eye for the evaluation to be a statewide evaluation and looking at sustainability and being able to prove that what Oklahoma Systems of Care was doing, being able to prove that that worked. And so from the very beginning, evaluation has been an integral part of the Systems of Care movement here in Oklahoma. We really look at service utilization and program effectiveness, and we also look at systems costs. We provide feedback to the central management at DMH, the statewide management, and then we provide leadership back to each of the county sites and the host agencies. So there are 77 counties in Oklahoma, and there are more than 100 agencies that provide systems of care services. Some of the larger counties, Oklahoma County, Tulsa County, have several providers. In Tulsa County, there are 6 providers. In Oklahoma County, there are 5. Some of our rural and frontier counties have 1 provider. Actually, many of our counties have 1 provider. And so we provide feedback for all of those, plus community stakeholders and the state legislature. And we look at outcomes information for those local sites. All of our counties are different. And then of course, we look at our data as a whole across the state. The way that we do that, E-Team designed a statewide online database we call the Youth Information System. It's a secure web-based application that is HIPAA compliant, and sites can enter data in it whenever they want. It's continually available, and you can pull down reports at any time from that site as well. You actually have to have a login to be able to get into any of the HIPAA data, but there is a public aspect to the site, so if you point your browser to the link on the slide, you'll see across the top of that page a tab called Resources, and on the Resources page are some publicly available reports. We'll have reports, statewide reports on special projects. Right now we have a big mobile crisis call center and mobile response that we initiated a little more than a year ago. There are reports there on that. Special reports for our work with DHS and the school systems, the Oklahoma State Department of Education, those kinds of things. And those are all public, so you're welcome to take a look at that. So we collect demographic and outcome data at enrollment and at 6-month intervals as long as a child, youth, or young adult is enrolled. In addition to the demographic and outcome measures, we also collect information about site staffing, caseload assignments, wraparound process and progress, family team meetings and composition, and flex fund expenditures. With the site staffing and the caseload assignments, we're looking at turnover, and we've been involved with some data sharing as we look at that with other states as well. So I already talked about this a little bit. The data in the YS are accessible on a continuous basis. Site staff can download and run reports for their own data, of course, but the state staff can look at reports on any county, any agency, and the state as a whole. And so DMH staffs 5 statewide coaches and several regional coaches that go out, and they use the YS a lot to look at coaching needs and training needs and things like that. And then in addition, I go out at least once a year to every host agency in every county, and sometimes it's multiple times depending on their need and what's going on with them and staff turnover and things like that. So we do a lot of training with the evaluation. It's ongoing and continuous. In addition to evaluation data, Oklahoma Systems of Care providers enter what they call the customer data core information into the PISIS, into ODMH SAS PISIS for billing purposes. That PISIS has, I don't know why they call it that. It has that acronym means nothing. But that's the data that is entered for Medicaid billing. And so we also access some of the PISIS data so that we can look at admissions and updates to CDC information and discharges and those kinds of things. The reason that we started that is so that we could have that data and reduce the data burden on families and staff. And so our sites enter the Medicaid or DMH number into PISIS, into the YS, and the YS pulls those questions in. So we're looking at, we don't have to ask 2 sets of demographic information, we don't have 2 sets of data entry, and we don't have data discrepancies between the YS and PISIS on client information or enrollment records or discharges. On our evaluations in our outcomes measures, we use the SWIC, which is the Survey of Well-Being of Young Children. It's embedded in the YS, so sites can actually administer any of these online as they go. We have some sites that bring their clients into their agencies, and they ask the questions right off of the computer screen. We have one host agency in particular that provides their staff with iPads, and they go out and they administer the assessments that way, and of course they can also be administered on paper for data entry later. I don't know if you're familiar with the SWIC. It's a parent report screening instrument for what they call here in Oklahoma the little bitties, so it's children under 5. It's a first-level screening for developmental behavioral domains, cognitive, language, motor milestones, social, emotional, behavioral functioning, autism, and family risk factors. And again, it's administered only to parents and caregivers at baseline and 6-month intervals thereafter. The Ohio scales, we actually use the Ohio scale, so it was great to hear that discussed. The Ohio scales was determined to be the measure that we would use from the very because it was free. We were allowed to modify it somewhat for Oklahoma's use. We were allowed to embed it in our assessments, so the Ohio scales actually makes up a piece of our assessments. We also look at the other things on the bullets here. So the Ohio scales enabled us to think about going statewide from the very beginning. It has 3 different versions. It has a parent-caregiver version, a youth worker, and a youth version and a worker version. It looks at problems and functioning scores that can be interpreted as clinically significant, and it looks also at clinically significant levels of improvement at follow-up. And then we added to that, Oklahoma looks at reductions in days out-of-home placement, school measures including reductions in tardies, absences, suspensions, and detentions, reductions in self-harm, reduction in contact with law enforcement, and these Ohio scales are also administered at baseline and at 6 months thereafter. In addition, we do administer the Wraparound Fidelity Index short form, or the WFI-EASY. This is administered to all of our wraparound families who are able to stay enrolled and engaged with the program through 6 months. So it's only administered at one point, but it is administered across the state. So we have, several thousands a year who are receiving the WFI-EASY. It is conducted by the wraparound providers themselves, and it gives us information on a caregiver's experience and wraparound, the team meetings, and outcomes and satisfaction. We report all of these assessments back to the sites. They can look at these on an individual youth basis, an individual family basis, and of course you can aggregate up to the county or host agency level. Some host agencies are in 1 county, some host agencies are in 14 counties, depending on that agency's catchment area and those kinds of things. So some of the reports that we make available to DMH and provider staff are provider reports at the agency level, the county level. And when I say outcomes, I mean we look at clinically significant impairment at baseline, clinically significant improvement at all follow-ups. We look at reductions in days out-of-home placement, all the school measures, self-harm and suicide, reductions in contact with law enforcement. We look at family measures. The family assessment measures a 10-item questionnaire that Oklahoma developed over 3 years of work with families. And so we look at all of those. We can aggregate that at a state level and up to the county level or host agency level. We also look at process reports so that we can understand how families and youth are progressing through Oklahoma systems of care. And so we look at active staff, active youth, caseload reports so that we understand how many families are on which facilitators' caseloads and what those families look like, the makeup of those families, and how that might impact facilitators. Assessments due and overdue so that we can help people keep track of that. We also, of course, have embedded the NOMs in the YIS, and so we are a part of the national evaluation right now for one of the expansion grants, and we do the evaluation ding-dongs, that's what we call it. We ding-dong them in several different ways to make sure that we have as many assessments and follow-ups completed as possible for the state and for the national outcomes measures. And so we have reports that can be pulled at any point in time that will say which ones are due and which ones are overdue. And then we do automated monthly emails that go out to facilitators and project directors at each county and agency level. And then for the national outcomes measures, we make a special email to them that the state receives a copy of, and we follow up with phone calls and things like that. Sometimes I feel like they probably get sick of us nagging them, but it's really important. We really need those numbers. So one of the things that we've done is we looked at return on investment, because all of this data collection, we want to be able to say that we are helping children and families across the state of Oklahoma improve outcomes. And we also have thought for a long time that we were saving the state money. That's one of the ways that we've grown across the state, is we've gone to the state legislature every year, and we talk about those measures that I talked about, days out of home placement, the school measures. We also tell them about the measures on the Ohio scales, but a lot of people don't understand that. They want real-world measures. They want to know how Oklahoma's children and family are getting better. And so we talk about that, and we wanted to be able to talk about, can we do that? Can we show those improvements and show decreased funding? Oklahoma was one of the first states to be able to charge Medicaid for family support providers. So they were instrumental in looking at how we access Medicaid dollars, how we grow this across the state, because it's all about sustainability, right? So we did a study on return on investment. We looked at youth receiving Oklahoma Systems of Care services and youth receiving standard behavioral health services. And those youth, we compared them so that they were similar demographically. The study population included almost 2,000 projected high resource utilization youth between the ages of 6 and 17 who were eligible for Medicaid. There were no statistically significant differences between the treatment and comparison group on baseline measures, and there were no changes large enough to be statistically different. Oh, I already said that. I'm sorry. So the total charges dropped significantly for both of those groups over time. The treatment group averaged a little under $40,000 in average inpatient charges in the year before the study, and $15,000, almost $16,000 in the year during the study. The control group averaged $28,632 in average inpatient charges the year before, and $23,691 in the year during the study. There was a 60% reduction in the average inpatient charges for the treatment group over time, compared to a 17% reduction for the control group. That averaged out, the treatment group experienced a savings of $357 per youth per month in behavioral health charges, compared to the control group for the study time period. And if you look at that over the 24-month study, it was $779 per youth. So we were able to say that not only were we helping children and families get better, we were saving money. One of the other things that we do is we conduct interviews and focus groups with leadership and staff from DMHS, the OKSLC providers, the partnering agencies, and community members, and participating families and children. Right now we're in the middle of doing community team surveys that will help us identify some issues we want to look at for focus groups. We use those insights to tell the story, to highlight our data, and just kind of put a face on that story, so that it helps people understand how the aggregate data is used across the state. I think that's it for me.
Great. Thank you so much, Geneva. We have some questions for you that we'll save until the end, but one that I just wanted to throw in here about ROI, return on investment. We've been using some of your data nationally in some of the work we've been doing on return on investment, and I'm wondering if you're still collecting and analyzing ROI data, or is that just a study that was done at that point in time, or are you still working on that?
We still look at cost savings for systems of care youth. We haven't done another comparison group because the issue, Oklahoma doesn't want to, I could look at cost only. Mm-hmm. I mean, in fact, I think we're looking at that for this fiscal year's data group or data set, but we haven't done a comparison group where we would go out and conduct the Ohio scale, the Oklahoma Systems of Care assessments. That's a fiscal issue.
Okay, great. Thank you. Just to mention that, as I said, that data is included in a report that we did on return on investment, and there is also a guide on how to conduct return on investment analyses that the TA network produced a couple of years back, and those resources can be made available to you as well. So thanks so much, Geneva. We're going to turn it over now to Connecticut, to Tim and Joy, to talk about how you're using evaluation of your children's behavioral health system there. So, Tim?
Okay, great. Thank you. Good afternoon, everybody. It's a pleasure to be a part of this, and thank you for joining us. So I'm just going to do a couple of opening slides that sets the context for Connecticut, and then I'll turn it over to Joy Kaufman, our evaluator from Yale, and I'll do one or two slides finishing up. But essentially, we have received our first planning year award the year following the tragedy of the Newtown shooting. And so what we were able to do, the announcement of the award to us for the planning year coincided with some deliverables for the state, in particular looking at how well our system of care was functioning and where some of the areas of improvement needed to be. And additionally, how to promote health as well as to try to how to round out the system of care. And so we had the first year planning year, and then we had the 4-year award, and then our current year we're in a no-cost extension. So we've been doing this. We'll be concluding 6 years. So one of the main focuses that we highlighted in our implementation was to make sure that family and youth voice was going to be embedded in all aspects. And one of the things we highlighted in both our grant application was to prioritize family and youth as part of the workforce, and that many of these concrete workforce development activities that we engaged in was to specifically target youth and families. And in particular, we developed what we called agents of transformation, networks of care agents of transformation. And so that was specifically on how well the network of care in Connecticut was doing and how it worked. And so that was our primary. But we then turned to other areas to include family and voice. And in particular, our evaluator, Joy, made the suggestion to have them more involved in the evaluation process. So that became really a priority for us, and we have found a number of kind of the secondary gains. So one, we would just say that prioritizing family voice, family and youth voice is a big important piece, and not to overlook evaluation as part of that. And one of the things that we basically said in all aspects of our implementation was that it's everybody's job to always invite, recruit, prepare, and support family and youth to be involved at whatever table. So that's a little bit of the context, and I'll turn it over to Joy.
Thanks, Tim. So this afternoon, we're going to provide for you 4 examples of ways that we're using evaluation and data in Connecticut. And the first 3 are family-driven processes. So the first example is our community conversations. These started during our planning grant. As Tim mentioned, we have the planning grant, plus it was right when the Sandy Hook crisis happened, and at that point our governor and the legislature passed a public act calling for the development of a revised children's behavioral health plan for our state. So in addition to the efforts across the state to gather input from professionals, leaders, and policymakers, we knew we needed a mechanism to collect authentic and meaningful data from caregivers and youth receiving services in the network of care. As an evaluator, I had previous experience training recipients of behavioral health services to conduct qualitative assessments using focus groups, so we decided to embark on a process of conducting community conversations led by staff from FAVOR, our statewide family organization. At that point, 6 FAVOR staff were trained to facilitate the community conversations, and others were trained as note takers to document the information that was collected. And over the past few years, these staff have been trained and now independently code the data, and they check for inter-rater reliability. They also independently analyze the data and have developed a process to feed the data back initially to the groups they gathered the data from, and then more broadly. The community conversations focus on 3 questions. and these are done annually. And the questions are, what are the strengths of Connecticut's system of care for children and families, major areas for concern, and how we should fix these problems. And we gather solutions from the family members. SABRE has just completed their 4th round of community conversations and conducted 33 conversations with groups in each region of our state, spoke to about 300 people, including about 1/3, 300 family members, and 1/3 of those who are youth receiving services. This process has provided us with data that has been vital to the development of our network of care, and the data collected in the first round of conversations essentially became the blueprint for our state's Children's Behavioral Health Plan. As we have moved forward with implementation of the plan, this annual process has helped us to see where we have improved and also areas where we need to focus to continue to develop our network of care. The second example is our Data 101 training. As we have worked to partner with family members in all aspects of our network of care, including their being in leadership roles at decision-making tables, it became clear that some family members have not had previous exposure to data, and therefore when data was presented at these decision-making tables to inform their work, some family members did not necessarily know how to be good consumers of this data. So with the goal of increasing data literacy, our evaluation team in collaboration with FAVOR developed a Data 101 training. Next, I'll share some slides from this training to give you a sense of what we're doing. This slide is to introduce the concept of medians to family, and the words I'll say now is how we presented in the training. So we talk about if you drive down a 4-lane highway with 2 lanes on each side, it is the median that separates you. Whether it's a strip of land or a guardrail, it's called the median. And the median is also the exact middle number in a sequence or a set of numbers. And a lot of times when data is presented, we hear about the mean or the average of the numbers. But if in that group of numbers there are some numbers that are really high or really low, they can influence the mean, and then it doesn't really represent the middle anymore. In a case like that, someone may also present a median, as it's the exact middle number. We then follow this slide with concrete examples to demonstrate how the median may be helpful for them to understand and how it may be helpful in their thinking about the data that's presented to them. The goal is that they take what may be new information and then we help them associate it with something they know already so that they'll remember it. Similarly, when teaching about the mode, we brought in a pie mode, showing them that by adding the ice cream, the pie is taller and it may represent the higher point on the line graph. So the mode is the number that happens the highest number of times. This slide also is used to teach them about line graphs, explaining the X and Y axis, and using how much lunch costs and the frequency of that cost can be displayed. So the example here is about lunch and frequency. Here's a slide introducing bar graphs. We explain how it is different than a line graph and how it is similar. We talk about the x-axis here that represents the number of goals and the y-axis. And this is one of the places where we help them to practice their knowledge by having the participants explain to us what the y-axis is. We ask them, is it a number? Is it a percentage? We then reinforce that learning through explanation, such as the x-axis can either be a number or a percentage. In this case, it's a number. The number of times a certain number of goals were made. In this last slide I'll share, we demonstrate how the data from the previous slide can also be displayed as a line graph. And through the line graph, we can easily see the mode again. And then, in helping them to practice new knowledge, we ask them, what's the mode? So the Data 101 training also reviews with them how to read more complicated charts and graphs, the types that they may see at decision-making tables, and teaches them to be data sleuths, to spend time looking at data presented, and to know to ask questions about things like sample size and statistical significance and the demographics of the sample and how it mirrors the demographics in the particular community. While this information may seem very basic to some, for others who may not have had as many educational opportunities, becoming comfortable with data and knowing how to read it is empowering and enables them to actively participate as full partners at these decision-making tables. The next example is the Connecticut Data Collaborative. We are very fortunate to have the Data Collaborative in our state as partners in our network of care. And as you can see from this slide, their goal is to democratize access to public data and to increase data literacy. The collaborative gathers data from public sources, things like census data, but also State Department data. and they work to make it accessible. Our former governor mandated that state departments make data available to citizens of our state through a data portal. However, the data on the portal was often difficult to access and to read. The Connecticut Data Collaborative brings this data in, cleans it, and makes it accessible via their user-friendly website that enables anyone to look at the data at the city, town, regional, or state levels. A few years ago, we began a process to obtain the data families were interested in. The current director of our family organization partnered with the state leader responsible for the data portal and worked collaboratively with a team of family members and the data directors from the 12 child serving agencies in Connecticut. The family shared with these leaders the data they wanted to see, and the leaders provided it, so that the very data families were interested in is now on the Connecticut Data Collaborative site. The types of data included in the collaborative site are things like population data from census, but it's then you could break it down to the city-town level or the regional level. Information about households, including poverty and needs, school data such as expulsion rates, and health data such as low birth rate or infant mortality rate. One thing that's interesting about Connecticut is that we don't have county government, and instead things operate at the level of either the city or town or at the state level. As we're working towards more integrated regional networks of care for children and families to enable an increase in access to service and reduce duplication of administrative structures, that getting data at the regional level was very important. Recently, the Data Collaborative created a series of data stories that present a myriad of information at the regional level. While this may not seem interesting or important to some, it's very exciting for folks in the regions as it's helped them to continue to plan for their integrated service array. So what the portal has done is it's enabled not only for folks to look at data at the city or town level, but they've integrated the regional structure into their menus to enable folks to pull data down at the regional level as well. So as an example, the data stories looked at disengaged youth, those young people aged 16 to 19 who are not in school or employed or in the labor force in any way. And this was an indicator of how youth are transitioning into adulthood. And if the rate is high, it indicates the need for additional supports to help these young folks engage. This is the data for one region that shows 5.1% of females and 5.8% of males are disengaged, and the state average is 5.5 for both males and females. And indicated that while the numbers are in this region right now are somewhat close to the state average, it's important to watch this trend, especially for young men, so that they can determine in this region if and when additional supports are needed. In summary, the Data Collaborative data stories provided information at the regional level and new and important information for our state. The Data Collaborative has made public data accessible to the community and helped both family members and providers to see the strengths and areas of potential risk and challenge for residents of the region. Importantly, the data has enhanced conversations and planning in the region. Now for a shameless plug, the first for 3 examples demonstrating how families are guiding our evaluation work in Connecticut has recently been summarized in a journal article that was published in Children and Youth Services. Finally, I'll share a bit of the work we're doing with data collection from families involved in care coordination and wraparound in our state. We are fortunate that, like Oklahoma, our Department of Children and Families has developed a web-based mechanism to collect uniform data from community providers who are working with families. Participation in this network, which we call PI, is a contractual obligation for providers, and they're held accountable to collect and enter the data. So some of the required data elements include the collection of the NOMs. We have a homegrown measure that looks at the child and family team process. Similar to Oklahoma, we use the Ohio scales, and we also use the caregiver strain questionnaire. We use the child trauma screen, which is a quick screen on exposure to potentially traumatic events and PTSD symptoms. And we use the CRAF, which is a substance use screen. All families, the data is collected when they first enroll in service and then every 6 months until discharge. So this is a summary of the data from our child and family team tool that we use. So care coordinators complete this tool at the end of each child and family team meeting that a family has, so that we're able to then aggregate the data up and look at it for a family, but also look at it for either a region or our state. So here we see that families had an average of 3 child and family team meetings within a 6-month window with a range of 1 to 12 meetings. And this showed us that meetings were not occurring monthly as recommended by the wraparound practice standards. So this measure is based on the practice standards, and then we assess how we're adhering to those practice standards. In addition, we see that on average it was 51 days until the first child and family team meeting, and the practice standards say that it should be 30 days until the first meeting. In addition to that, you see things like our meetings lasted a little more than an hour, about 6 people attended the meetings, about 28% of participants were natural supports. Practice standards say it should be 50%, and none of our child and family team meetings had 50% of natural supports or more. And in our network of care, the target children attend an average of 2 out of the 3 meetings that occur for their family. So when we examined the relationships between child and family team characteristics and some of those outcome measures we collect, we found that there were some significant findings. First, we found that families with more child and family teams tended to have poorer outcomes. We saw significant increases in ratings of youth problem behaviors and impairment, and increases in caregiver strain and decreases in youth functioning. We also found that longer meetings were associated with lower ratings of youth functioning, which could reflect that families with more complex needs have more to discuss, so the meetings take longer. We found that more days to the child and family team meetings was associated with higher youth impairment and caregiver strain, the caregiver objective strain, those tangible disruptions like financial strain. So perhaps families with this type of elevated stress may struggle to schedule and maintain appointments, which could interfere with their ability to quickly engage in the child and family team or wraparound process. So this may represent a subset of families who may require increased support and effort on from care coordination staff to reduce barriers to engagement. We also found that a higher percentage of natural support at the meeting was associated with better outcomes on nearly all of the measures we looked at. And this may mean that families with more expansive social networks may be better equipped to use resources or may have associated skills that allow them to effectively use the child and family team process. It may also mean that youth with more complex needs may require the involvement of more professional support, which may inherently lead to a lower percentage of natural support. Finally, it could mean that increasing the presence of natural supports, even to a lower percentage than recommended in the practice standards, could lead to improved functioning. So what we're finding is, for our folks in Connecticut, we're finding a difficulty to fully implement the child and family teams in a manner that's consistent with the national wraparound practice standards. And so in looking at this, we wanted to provide direction for our work, but also perhaps other areas who are seeking to implement an effective care coordination process. So as I said, we found it's difficult for communities to implement CFTs in a manner consistent with the standards. For example, we found that 51 days before families had their first meeting, while the standard is 30 days. Again, may reflect difficulty in engaging family and system of care services and suggest that systems of care may not be effectively meeting their needs. It also means that providers may need to identify families undergoing transition or crisis to provide additional support so the family can actively engage. The findings also suggest there may be opportunities to identify areas of flexibility with regard to the fidelity to the practice standards. And although our sample participated in 3 child family team meetings over 6 months, fewer meetings were actually associated with better outcomes. It's possible that the CFT process is so empowering for some families that they don't require monthly CFTs in order to achieve the benefits of improved support and care coordination. So reducing the frequency of meetings for families who take a more immediate lead in the CFT process may enable care coordinators to allocate more time for families with more complex needs who might need additional support and coaching. And finally, as I said, we found improved outcomes despite failing to attain a target of 51% natural supports in meetings. And likely the number of natural supports may be more individualized than the practice standard suggests, and identifying what works for each family may be a more achievable goal. Future work is needed to delineate the mechanisms of change within the CFT process to guide the continued development of the wraparound model. And future research should also continue to empirically evaluate the practice standards. So some other work that we're doing is that we're in the process of work to identify risk profiles for families presenting for care coordination. So these are being developed based on risks that caregivers identify when they first, when families first come into services. So these are risks related to the caregiver. And as is illustrated in the slide, what we see is, so the slide here shows the frequency of the caregiver risk. So what we did was we conducted late-in-class analysis to see if these risks held together into some profiles, and the model with 3 classes was the best statistical fit. And what we've identified is a basic needs class, where issues such as poverty, unemployment, and housing were needs identified by the caregiver. A mental health and substance use class, where caregivers had a high probability of identifying mental health needs and are less likely to identify other needs. And a low needs class, where caregivers identified that they had few, if any, needs. This slide shows how the risk factors loaded onto the classes. The red line is a basic needs class, and here you see the highest endorsements for issues like poverty, housing, and transportation. Mental health and substance use in purple loaded the highest in that area, while also having low levels of some basic needs. And finally, the low needs class identified very few, if any, needs. We are finalizing the classes for both the caregivers presented here and also for our latent class analysis for youth this summer, and then hope to examine the classes in relation to the child and family team characteristics and eventually to the outcome measures. So another shameless plug, paper summarizing our work, examining the relationship of the child and family team characteristics and outcomes was recently published in the Journal of Community Psychology. I'll now turn this back to Tim.
Yeah, so in summary, I think we shared in the opening that really getting family and youth voice involved, including your evaluation process, what we discovered was we had many, many different secondary gains, and we pointed to a few. One of them, the development of the Data 101, and we're now moving on to Data 201 and some other advanced classes. We're also finding that family members are becoming much more savvy around data and data use. The Connecticut Data Collaborative had done a data academy for providers, and they extended it to create family and youth slots, and we've been really excited about that. And additionally, what we just started to do is to go into some of the schools and assist schools in doing some data introduction to using public data. So that's been really fabulous and a great secondary outcome. And then finally, it's all systems probably can use more youth and family involvement, but what we found is when you get them involved in evaluation, their numbers of involvement in all other aspects of your system of care also increase. So we're really excited that this we stumbled upon this or kind of made it happen, and it's been a great experience for us. So thank you.
And thank you, Tim and Tim and Joy for that. There are a few questions that I'd like to raise at this point. One for you, Abram. Assuming that there are costs to the measures you mentioned, like the CANS, CAFA, CBCL, and such, can you talk a little bit about that?
Yeah, there are costs to some of the measures, as you heard. Some measures like the Ohio scales are free. The Columbia Impairment Scale is free. The Pediatric Symptom Checklist was free to the grantees we worked with, but isn't necessarily free. And I think the sort of broader issue is there's kind of 2 sets of costs. You know, there's the cost that comes with having to purchase actual instruments. There's also costs that come with implementation and training, and different measures have different costs associated with them. The CANS is a good example where the measure itself, I believe, it was when I was using it, is free. However, the training costs are, to use it correctly, are significant. So there's a bit of a mix, and it's important, I think, just as many of you know, but it's just important to evaluate where the costs lie, because sometimes a free measure may cost a lot to implement, and sometimes a measure that costs a bit to buy may be easy to use. So I don't know if that helps, but that's sort of my basic thoughts about that.
Right, very helpful. Thanks, Abram. And then for you, Geneva, there are a few questions about Oklahoma. Who manages the YIS system? And,
we do here. Oh, sorry.
No, go ahead.
We do here at the E-Team. We are constantly updating it to provide new reports and just increase what we're doing. And so we developed it, we code it, we manage it, we do the data, we do it all.
And how is the creation funded, and does it continue to be funded through the same mechanism? How is it funded now?
It was funded through the state. And like I said at the beginning, DMH has always had a commitment to evaluation and wanted to make sure that we could prove that the services worked. And they've used the data for sustainability for the whole growth period from the beginning. So I won't say that it's cheap to do that, but we are cost effective. We provide a lot of training to sites and everything on that, and I think it pays off. And I would argue that the evaluation pays for itself, but the state does continue to provide financial support for the development and ongoing maintenance of the data system.
Great. Thank you for that. Denise, you had a question, I think, about Family First.
Yeah, I was wondering if Connecticut and or Oklahoma are using your outcome data or any of your data to help advance your Family First Prevention Services Act planning.
Hi, this is Tim from Connecticut. I would say we're doing it indirectly, but I'm not aware of anywhere that we're directly using it yet. Where it's been most helpful to us was our strong care coordination outcomes have been very useful in helping folks make decisions about where the different areas where Connecticut might focus on, but a lot of our area, we're still in the planning and thinking phase about that. So kind of a lot of our, and I would say also our systems of care assessments, in particular the community conversations that Joy highlighted, a lot of that data has been used to inform kind of our thinking about how to move forward on that.
Okay, great. Thank you. Any other questions? I don't see any more in the chat box. If any of you have additional questions, we still have a few minutes left.
Selby has shared the tool that they use, the assessment tool in Oregon. Thank you, Selby.
Okay. And do any of the presenters have any final thoughts or comments that you'd like to add before we wrap up?
No, I'm good. If anyone has any questions for me, if you go to that website, at the bottom of every page is a link to the YS Help Desk, and you can reach E-Team through there if you have any questions. And feel free to look at any of the reports and let us know if you have questions.
Anyone else? Okay. I think we'll wrap up now, and presenter contact information is in the PowerPoint. And I'd like to first thank our presenters again, Abram, Geneva, Tim, and Joy, for outstanding work on this learning community session. I think they've left you with a lot of ideas and a lot of strategies that you can apply in your states and communities, and I know that you can reach out if you need some additional information about that. Again, I'd like to ask you to hang in for just a couple minutes longer and use the link that will pop up to complete the brief evaluation survey. That would be helpful. And thank you also to Tiara Brown from the TA Network for handling all the tech aspects of this session and for doing it so well, as she always does. And one more plug for the next Learning Community meeting. That'll be on June 19th on custody relinquishment, and Tiara did put the links in the chat box. And thanks to all of you.